Am I good? Can you hear me? Okay, let me get this out of the way. Okay, today is about putting it all together and taking kind of the concepts that we learned and try to give you some kind of working formulation or working paradigm that we could use. Am I okay over here or? Oh, wait. Hang on.
There we go.
There we go. Okay, so this is probably a good opportunity to figure out how to deal with some of the current things that we're dealing with. And long COVID is always, it seems to be more and more prevalent. So the definition of long COVID is greater than 4 weeks of symptoms. It's also called post-COVID condition or post-acute sequelae of SARS-CoV-2, PACS. You'll see that in the reporting and in the literature. But remember, it's not just, we have to think web-like. It's not just about silo thinking. GI, brain, neuro, endocrinology, immunology. We have to put it all together because the body is a web. So the symptoms are typically fatigue, worse with physical effort, fever, breathing, lung symptoms, joint or muscle pain, neuro symptoms, especially brain fog, increased headaches, heart conditions, palpitations, persistent diarrhea or GI complaints. And there's also blood clots and vascular issues, could be anywhere. And COVID is really about the endothelial disruption, endothelial malfunction. Endothelial, for those who don't know, the endothelial layer is that one cell layer thick lining of all the blood vessels. So that's called the endothelial layer. Okay, so we always want to play defense when we can. So you should, before we, if we want to treat something, the best way to treat it is to prevent it. So you should have a preventive protocol in place, and then encourage people to reduce their comorbidities. Number one comorbidity for COVID is obesity. They just found out that the SARS-CoV-2 virus replicates in fat cells, adipocytes. So that's why people with obesity, especially morbid obesity, were more likely to succumb especially at the early part of the pandemic. So treat cases early and aggressively. At the beginning, it was like, well, there's nothing we can do, so you just stay home until you just about can't breathe anymore, then come to the hospital, we'll intubate you, and then you will die. Paraphrasing, but that's just about how it was. But in my clinic or my office, we treat cases aggressively. Okay, we put them on vitamin mineral protocols, we put them on pharmaceutical protocols. We want them to get better fast, and then we follow up typically within 2 weeks. If they're not getting better, then we try even more aggressive strategies. This group, frontline critical care docs, Lynn spoke yesterday. The Surgeon General of Florida was a member here, and they have up-to-date treatment protocols. I mean, up-to-date, I didn't even bother putting it up here because it's changing all the time. Right now, it's about 3 pages long, the first, second, and third tier interventions. So that's probably the place to go for up to the minute. Okay, so the first line therapies, prednisolone, some kind of steroid treatment to decrease the inflammation. Ivermectin, which was pejoratively described as a horse dewormer and other sort of bad things, but it's been proven over and over in studies to be very effective. Earlier the better. It's weight-based, so it's 0.2 to 3 milligrams per kilogram, and it's daily for at least 2 weeks. Sometimes I keep it on longer if I don't get the resolution or the quick improvement that I like. Low dose naltrexone that we talked about yesterday and probably the day before. It's good anti-inflammatory, but you have to build up to it, so you have to leave it on for at least 2 or 3 months for it to take effect. Intermittent daily fasting or periodic daily fasting. Again, we talked about autophagy yesterday, and we need to have the body get up to speed cleaning things up. Spermidine or resveratrol rather. They're compounds that stimulate autophagy. So it's about cleaning up, taking out the garbage. Melatonin, 8 milligrams at night at least. It's a better antiviral than it is a sleep aid, especially for the brain. Vitamin D, it was another comorbidity, was having insufficient or deficient vitamin D status. So you want to supplement with vitamin D at least 5,000 units a day, probably 10,000 units a day. To get that up, omega-3 fatty acids, you can use the, yes.
If somebody's not deficient, it will still be the same?
Yes. Yeah. So if they're not deficient, so the normal vitamin D level, at least on Quest Labs, is 30 to 100. So you're going to get that threefold, difference in normal. So we want them at least 60 to 80, and probably if we're fighting something acutely, you probably want them really close to that 100 range. Right? So if they're at 35, they're going to get at least 10,000 units a day. If they're at 65, I probably give them 5,000 units a day just to get them up towards that 100. Yes, ma'am. Absolutely. Oh, yeah, absolutely. Yeah, I would get this on right away because you never, while they have lower risk, that doesn't mean they're immune to it. So I want to be aggressive with conservative care. And so I want to prevent long haul COVID, because even though they don't have the comorbidities, they're still not out of the woods, and there's chances are lower, but they're still there. So the omega-3 fatty acids, it could be the DHA, EPA that we talked about. There are pharmaceutical grade, Lavanza, et cetera. 81 milligrams of aspirin daily or nightly to help with the endothelium, just help from clotting in the endothelium. And turmeric, 500 milligrams twice a day. This is not an all-inclusive list. This is basically what I use to hit things quick and hard. Okay, second line therapies, fluvoxamine, 50 milligrams twice daily, atorvastatin. Statins not only decrease cholesterol, but they're probably more effective because they have anti-inflammatory properties. And that's probably how they work better, for cardiovascular disease. Hydroxychloroquine, 200 milligrams twice daily for the first couple of weeks, and you can titrate it down. Failing all that, or if they're not still improving, IV vitamin C, at least 25 grams. We do that in our office routinely. We go up to 50 grams or 75 grams infused. If you're infusing vitamin C, you do not get the GI upset from the heart, from the large doses. That's an osmotic effect from the vitamin C. You don't get that when it's infused. Some kind of mitochondrial energy optimizer with PQQ, so coenzyme Q10. There are different combination formulas out there. And N-acetylcysteine, 600 to 1,500 twice a day. I don't think it matters. I think it's more just the anti-inflammatory effect of the statin. We're not treating cholesterol, which we're using for its anti-inflammatory effect. Yes, ma'am. No, you'll see that in the various nutritional formulations. Okay, and then some more adjunctive therapies. I'm not going to probably read them, but you could read them. This is like third line stuff. If you really hit it hard at the beginning, you know, this stuff is pretty, you know, we very rarely have the need to do this. And I'm more aggressive with the IV nutritional therapy if they're local to me. I was like, okay, let's get you in for high dose vitamin C or something else I'll show you in a second. My secret weapons. Hyperbaric oxygen we talked about. This is particularly good for brain fog conditions. We had a paramedic who called us up and said, I had COVID. And this is very early in COVID. He said, I have brain fog and I can't get rid of it. And I've had COVID. It was over a month ago. Can I come in and get some hyperbaric treatment to see if it works? And I'm like, okay, you know, it's not going to hurt you. You can breathe, right? Yeah, I can breathe. Okay. So we put him in the chamber. After eight visits, his brain fog was completely dissipated, started getting better after the second one. So then we start using it for that. And then I have a thing I use in my office. It's called ultraviolet blood irradiation with ozone. So we take your blood, we take 60 cc's of your blood out, we put it in a saline bag, we ozonate it, and then we run it through this machine that has ultraviolet, 4 ultraviolet bulbs in it. So it's another form of photobiomodulation. We're putting photonic energy into the blood, and we carry that back into, and we reintroduce it back, and, you know, we're giving your own blood back into the system. That acts as an immune system modulator, and it will also increase and help fight any kind of infectious diseases. We also use it for autoimmune diseases too. It's one of those modulating kind of therapies. But these are my secret weapons. This is what I go to if the oral stuff is not working after a week or two. Because really what I want to do is prevent long COVID. And I tell my patients that. I said, okay, we're going to treat for this, but what I really want you to do is prevent this from being an ongoing concern for you. And everybody appreciates that. Okay, resistant hypertension is another thing that is talked about recently. Is people can't get their blood pressure controlled in spite of use of 3 agents. Okay, so what's going on there? So first thing we do is we look at their micronutrient status. So we'll do a test that we talked about yesterday to look at we take their white blood cells out and we can look at the micronutrient panels in there, vitamins, minerals, and see how they're doing there. We want to know their nitric oxide level. We want to give them something to increase their nitric oxide production. Again, now we're worrying about the endothelial layer, okay, which is very important. It's in endothelial dysfunction that gives you, one of the things that gives you hypertension. We'll give them a high dose of mixed magnesium, so not just one kind. If you give a lot of mag citrate, you'll get diarrhea. If you give them a lot of mags oxide, which I never use, you'll get a lot of GI complaints. So we use different kinds of different formulations of mag-threonate and magnesium bisglycinate, or any kind of chelated magnesium would be fine. We make sure their antioxidant status is up to snuff. We give everybody methylated B vitamins just in case they have that MTHFR, single nucleotide polymorphism that we talked about yesterday. We give EDTA chelation therapy. That's a chelating agent that will decrease your blood pressure. And when we do that for cardiovascular reasons or for heavy metal reasons in my office, we routinely monitor their blood pressure and their hypertensive medication status, because it'll easily drop their blood pressure and you can make them hypotensive if a lot of times we have to pare back on their blood pressure medications. Carbohydrate restricted diet, time restricted eating. We talked about that yesterday, and you guys are going to talk about that when we discuss lifestyle interventions. And exercise therapy, be cautious at first. You don't want to take somebody's blood pressure from a very high level to extremely high level if they're not tolerant to the exercise. Okay, so endothelial function, we look at their nutritional deficiencies, their oxidative stress, and we look at their insulin function. The best way to do that is do a fasting insulin level in the morning. Okay, so you look at their glucose level and their fasting insulin level, and then if you don't know if it's a problem or not by that number, you can give I use a 4-hour glucose tolerance test, because a lot of times 2 hours doesn't catch the pathology. And every time you do a glucose tolerance test, you should be measuring not only glucose, but insulin at the same time. So you want to see how the insulin is tracking with the glucose.
What's the ratio of insulin resistance?
I'm sorry, can you repeat the question?
Like the ratio of insulin to your fasting sugar. Right?
Oh, yeah, so you want to see if, so if they take, I don't know if there's a direct ratio, I just look at the trends. And if there is a lot of insulin, if it's like 50s or 60s to get their glucose to a normal level, you know that they're getting insulin resistant. Yeah, not as specific. I mean, you could, and you pair that with the hemoglobin A1C to try to get the average blood glucose level. So you're looking for, you're just looking for the rate, the trend, and not necessarily a hard number. I don't know how this got in here. This is from yesterday's lecture. Oh, well, I know why this isn't here. Well, next part of the program is their homework assignment, which is that we're going to develop a healthy lifestyle plan. The only thing I was looking for now is the case study.
So the case studies are, in the handout, but remember I mentioned that they're not, I didn't have slides.
Okay. Can we put it into the computer? Okay, we're back.
And just kind of pay attention to it.
Okay. Oh, by the way, I put my email address on the board over here, and there's a couple of, or if you like this sort of thing, there's a couple of organizations you might want to think about looking at. IFM.org, Institute of Functional Medicine. And then there's PLMI, which is Personal Lifestyle Medicine Institute. That's Jeffrey Bland's second organization that he created. He created IFM. And then for the docs in the room, there's AAMG, Advanced something medical group, and that's basically, they do a lot of stuff with the hormone replacement that we talked about. IFM is not mostly MDs, AMG is mostly MDs, PLM is hardly any, and PLMI is hardly any MDs, I believe. Okay, so we're going to talk, this is systems thinking, so we're going to think systematically, right? So this is a case I had quite a number of years ago, but I still use this as an example because I like the case and it tells us a lot of how to think. So chief complaint was heart palpitations in a 46-year-old female, heart palpitations, anxiety, and fatigue for 8 months duration. She came in complaining of primarily fatigue, but then you drill down a little bit and then you ask, okay, so you do a complete history. Okay, what was going on at the time? What other things are bothering you? Because the docs are trained to ask for chief complaint, right? Well, it should be chief complaints, right? Because if we're thinking systems, a lot of these things are not that clear cut. So her symptoms started within 2 days of started with 2 days of diarrhea in a September 6th and a September 7th. Okay, and then the next day she had a feeling of falling while supine. Well, that's kind of interesting, right? She's laying on the bed and she feels like she's falling. Okay, so that leads me to believe we got some nervous system involvement, yes? Okay, so there's some perceptual issues there. So she goes to the emergency department. They said, "Oh, you got a virus. Go home. You'll be fine." But the diarrhea continues for 2 weeks, and then she gets tachycardia. So now we have the nervous system, we have the GI system, and we have the cardiovascular system, right? So the body is not silos, the body is a network. So she goes back to the emergency department because now she's got a racing heart. They do an echo. She's got mitral valve prolapse. They give her a beta blocker. And then they send her on her way, but she still has intermittent tachycardia, even despite being on the beta blocker, right? So she's getting intermittent palpitations. Uh-oh. Okay, so she goes to the gastroenterologist. They do an upper and lower endoscopies. Everything's negative there. They put her on probiotics for the diarrhea. So then she goes to the cardiologist. They give her a stress test. That's negative. They continue on the beta blocker. But then somebody decides to send her to the psychiatrist for her anxiety, and they give her Xanax.
Okay, there you go.
Past medical history, she has environmental sensitivities, especially mold. She works, she's from Florida, so there's a lot of moldy buildings, especially like teachers. I see a ton of teachers in South Florida who all have mold exposure. I don't know if they install mold in the buildings when they build them. I don't know what they do, or they're so old, but every teacher seems to have mold. And that's why, they're always complaining about stuff. So she's on the, so somehow she got switched from Xanax to lorazepam, but she's still on the beta blocker. Her father had an MI of 47, so now we have to think about, well, okay, does she have cardiovascular issues? Her mother has hypertension, IBS, celiac disease, and food allergies. So she's in the more sensitive type of, the mom, the celiac disease, the IBS, more sensitive kind of person that I see a lot in my office. So she's an accountant. She's not typically, your high stress, anxious kind of individual. Although she was a former smoker with a 33-pack year history. Okay, so interestingly, I'm quizzing her because you really, when you're spending, you have time to talk to your patients, like what makes this better, what makes this worse, you really get to drill down. Pizza exacerbates the tachycardia. Okay, well, that's interesting, right? The digestive enzymes improve the tachycardia. So now we have the GI system talking to the cardiovascular system, probably via the brain, right? Because there's direct contact or conduit from the GI system to the brain we talked about yesterday, with the gut-brain axis. Stress, crowds, and odors exacerbate her symptoms. What does that tell you? Stress, crowds, and odors exacerbate her symptoms. What does that tell you? Well, yeah, so the nervous system is revved up, right? So the nervous system is very perturbable. So any little thing can set her off now. She's very sensitive to things, especially when people are sensitive to lighter odors, especially odors that really that really lets me know that there's something going on there. And rest improves her symptoms. Well, that's typical, right? Physical exam, her blood pressure was 116 over 62. The vitals are totally normal. Unremarkable physical exam. No, nothing was tender, nothing was big, nothing was small. Everything was fine. Some impressions: palpitations, tachycardia, right? Fatigue, mitral valve prolapse, and probable dysbiosis. So the pizza was aggravating her things. Digestive enzymes improve things. So I have to figure something's going on in the gut, and there's probably something that we need to take a deeper look at from there. So we did a comprehensive stool analysis with parasitology ×3, meaning there's 3 separate collections over 3 different days. That improves if you do over 1 day, you get basically a 50% specificity. Over 3 days, you get like a 90%, but it doesn't improve after that. So there's no sense going to 4 or 5 days. 3 subsequent days. Or if we pay 3 days out of 7, but the first 3 days you can. So people who have chronic constipation, they might not go for 2 days, right? Oh, and by the way, constipation in my office is defined as not going at least once a day. Okay, so that's constipation in by definition in my office. Okay, we want to check her MTHFR status, right? We've been talking all weekend or week ago about MTHFR, methyl tetrahydrofolate reductase. Remember, people who don't, 25% of the people don't methylate well. So I check that because anything that has to do with the nervous system, and by nervous system, I mean nervous system function and brain function, psychiatric kind of things, addiction, I always check MTHFR status because more likely than not, those people are more predisposed to nervous system conditions or neurological conditions. I want to check her MCV levels, cytomegalovirus, because cytomegalovirus likes the nervous system. And I want to make sure that she doesn't have an unchecked or high MCV titer. I want to check her vitamin D levels because vitamin D is a hormone. I check vitamin D levels routinely on everybody. That's part of my basic workup. And then, well, let's consider a mold sensitivity workup or mold exposure workup. There's 2 sets of problems in my office. When you can't figure it out, look for Lyme or look for mold. Because those are they could be anything. They can manifest in any kind of weird kind of symptom. So a mold workup, which is, we looked at it yesterday. It's in your handout, the mold workup about inflammatory markers that we look at in the blood. We do a provoked challenge with glutathione to look for mycotoxins that come out in the urine. And we also we look at IgE sensitivity to mold, to different molds. So that's a kind of a 3-pronged way that we look to see if the person's has a mold involvement or not. I'm more sensitive to it because of where I practice. Although you can have mold anywhere, I've had mold patients who were very sensitive. They tried to move to Arizona and different places. They still had mold out there, and they were still very sensitive to it. They wound up moving to Florida, back to Florida. So what would you like to test? Would anybody like to add anything to that?
You know what the ER did, lab work wise, so far?
Well, you know what ERs do, right? They would do a CBC chemistry. You've got decent vital signs. You're not going to die in the next 24 hours. You can go home. Yeah, I was impressed that they did an ultrasound actually in the ER. I was very impressed about that. But that's kind of an ambulatory thing. They were like, you're not going to die. We don't need to admit you to the hospital. Go follow up. So she followed up with cardiology. She followed up with neurology. Okay. Her mom had it, right? Yeah. So that would be a good thing to test her for, right? Anything else? I mean, we know we're going to check her vitamin D level. You know what I checked, right? But see, that would be a good thing, or some type of autoimmune screen. Like an ANA, at least a screen with a reflex to, certain things. Yeah, well, I assume you walk into the ER, they're going to check your blood sugar and yeah. So I assume that was normal, and then of course we did a CMP and CBC, routinely. Yeah, well, her vital signs were normal, with us, but yeah, we would do a CMP panel. We do that on everybody, CBC, CMP. That's standard. Just walking into the office. Okay, so we checked her vitamin D level 38, right? So normal, quote unquote, is 30 to 100, but we want them 60 to 100, right? Because that's the beneficial level. Okay, MTHFR. She has 2 of the worst polymorphisms you can have. Okay, so she loses about 70% of that gene function. The MTHFR gene codes for the methyl tetrahydrofolate reductase enzyme. Okay, and she's got 70% defect in that enzyme, which means she doesn't methylate well. She probably doesn't detox well. Okay, She's not activating her B vitamins. Well, B vitamins, we talked about yesterday, very involved in the nervous system function. Okay. She had an elevated cytomegalovirus titer. Once you get viruses, they're still in your system, right? And then if they're, if they're at bay, if they're kept low, then you have low immunoglobulin functions. You have IgG numbers. So we did a comprehensive stool analysis. She had Proteus, she had moderate amount of yeast, but she didn't have any Giardia or crypto, but she did have Endomyelitis and she had cysts and troughs, so she had parasites. Okay, she had moderate yeast, she had some Proteus, which is a bacteria overgrowing, but she had parasites. So now my impression is parasitic infection, yeast overgrowth, mild bacterial dysbiosis. She has the MTHFR homozygous gene, 70% decrease in function, and she has vitamin D insufficiency, right? If you're under 60 in my office, I call it an insufficiency. If you're below 30, I call it a deficiency, although that's not quite the accepted terms for the CDC, et cetera. They want you below 20 or something like that, but so I put her on metronidazole for 2 weeks, neomycin. Well, you guys are all pharmacists mostly, so you guys know what this is. It's parasitic medication. Neomycin is a non-absorbed antibiotic. I was told by an old surgeon that's what they used to use for bowel prep. They used to give them doses of neomycin to clear everything out. Put her on nystatin for the yeast. We gave her methylation support, meaning B vitamin, activated B vitamins with methyl donors, dimethylglycine, trimethylglycine. Put her on vitamin D. We put her on a gluten-free diet because everybody should be on one. We talked about gluten increasing zonulin. Zonulin increases intestinal permeability. And I followed up with her in 6 or 8 weeks. She did well for a month and started having symptoms again in the second month. Why she didn't come in when she started having symptoms, I don't know. But I retreated her with the metronidazole and nystatin, and then we saw her again to follow up. 6-week follow-up, her symptoms resolved, her energy improved, and she no longer needed the lorazepam. Right? We took care of her parasites, and the anxiety went away. So then I sent her back to cardiology to taper and DC the beta blocker because she wasn't having palpitations anymore. Why didn't I just take her off the beta blocker myself? No, I wanted a cardiology to see what I did. I thought maybe I'd get a phone call. I didn't, but I just wanted, so I just wanted to see other people, it's like not just your specialty. Everything is a web. Everything is connected to everything else. You can get that anywhere. We routinely find you can get it. If you have salad in a restaurant, you can get it anywhere. It's not like she was out like in the backwoods, like swimming in lakes or things like that. I mean, she's an accountant from Fort Lauderdale, Florida. She's she's not going to. She's not out in the. I assume she was not out in like the Everglades, like wrestling alligators or. Mm-hmm. Oh, if that was causing the problem? Yeah. So I would have put her probably on some kind of antiviral, natural or pharmaceutical, depending how bad it was, just to quench that type of thing. I routinely test out anything like from above the neck and headaches. I routinely look for that. Did you have anything on systems thinking that you wanted to present?
Yeah.
We did the long COVID and we did the persistent hypertension, and I just did my case of parasites leading to anxiety and palpitations.
Are your slides still going? Or is that the end?
That's the end of it.
Okay.